So here we go. We're going to be talking about Chapter 13, posture. This fits in really nicely with Chapter 4 about the vertebral column. And let's dive into some of this material. We're going to start talking about what happens with aging, and these are the typical age-related changes as a result of gravity and change in lifestyle as we get older. As you look at this image, one of the things you'll notice if you look at the height of the head, it does start to diminish. Primarily, we know in our 50s and 60s, we start to have significant loss of height due to the loss of intervertebral disc size or height. At the lumbar spine, it may start at 9 millimeters as an average height, in the cervical spine, 3 millimeters, and we know that may drastically reduce, possibly decrease in half or even greater than half between the 6th, 7th, and 8th decade of life. But besides the height changes, you'll probably notice that there are some curvature changes. So here you have the typical lordosis, kyphosis, lordosis, kyphosis. Ultimately, the kyphosis here in this range doesn't really change because that's a fixed set of bones. There's not really much change in there. However, there is significant pronounced change with the thoracic kyphosis. You could see it starts to increase, and you could see that change throughout the lifespan. Now, why does that happen? Why does the thoracic spine tend to have an increased kyphosis or an increased convexity posteriorly? Part of that has to do with the head position. Generally, we're looking for the external auditory meatus to line up pretty much in line, if you were to draw a plumb line, with the acromion. And with the acromion, it should generally line up, I can't draw a straight line here, but greater trochanter and the iliac crest would be there. So it should be pretty much a straight vertical line. And the textbook has some pictures of this if you were to look at someone from the side angle. But instead, as you get older, the head starts to have that forward head position. And as the head shifts anteriorly, that's going to decrease the lordosis at the cervical spine, and it's going to increase the kyphosis at the thoracic spine. So if you're looking for the visual representation, this is good. However, if you're looking more for a table about this and some numbers associated with that, this would be a good slide to know because you can see what changes occur over time. So at the cervical spine, you see you have about a 9-degree lordosis, and that changes all the way up to a 22-degree lordosis. What about a kyphosis? So you can see 38 degrees goes to 45 degrees. And the lumbar spine, there's really only a small change here from the lordosis. This is definitely going to be lifestyle related, but there's not as significant of a lordotic change there. Some of these other terms you should be familiar with. So if you look at this chapter, you're going to see a good image there about what is pelvic incidence, what is sacral slope, and what is a pelvic tilt. So make sure to look out for that. It's also in a picture at the very end of the PowerPoint, so you should know what those three terms mean. However, you don't have to worry about the numbers significantly for these three terms. However, I would focus largely on the numbers for these three because these are things typically we can see when we observe a patient's posture, especially if their shirt is off and we have a good view of them. They're also pretty easily to see on an X-ray imaging as well. So let's talk about that, an X-ray imaging that shows a lot about the alignment of the spine. On the previous slides, we were talking about the movement in the sagittal plane, the flexion and extension. However, with scoliosis, as pictured here, which plane of movement are we looking at? We are looking for any kind of alignment or malalignment within that frontal plane. Now, in the frontal plane at the shoulder and the hip, usually referred to ab and adduction, but at the spine, we refer to that movement as side bending or lateral flexion, left lateral flexion, right lateral flexion. And you can see scoliosis here. Now, it might be from an unknown or idiopathic cause, or there could be some other environmental genetic reasons for that. It definitely can be carried on for that route, but there's also a lot of unknown other reasons that metabolically or otherwise that cause a significant scoliosis. I do want to mention that the majority of people do have some degree of scoliosis. It's sort of like your teeth. There is some degree that almost everyone has where it's not completely straight. There is some crookedness to our spines. But we typically don't diagnose it as scoliosis unless it's a significant amount of convexity and concavity in the frontal plane. So this is obviously a significant amount. So that means we need some way to quantify this. We need some way to determine, does someone have a scoliosis? And that's where this angle comes into play here. So if you see here, we have this angle. So if you were to look at the curve, and so you can see obviously a curve right there, there's a convexity to the right and a concavity to the left. So that curve, well, if we were to measure that curve and this type of angle, that would give us the Cobb angle, C-O-B-B, just like the salad, Cobb salad, one of my favorites. So I like that. And with this, you're going to measure that on an X-ray. A radiograph is going to be the way to measure that. We can try and estimate that clinically. One of the tests that sometimes you'll see is with your hands in front of you. You're going to bend over, not sliding your hands along your legs, but just letting your arms and hands dangle in front of you. And you're going to see if one upper extremity is longer than the other. And if one is longer than the other, and you can maybe stand up and think about this, if I bend forwards, and if I shift my weight to the right and I do a right side bend, all right, so I just posted the question there. So if I'm forward bending and I'm doing that with a right side bend, not all the way into right side bending, but maybe about 10 or 15 degrees into right side bending, which upper extremity appears longer? It's going to be the ipsilateral upper extremity. So the right arm is going to appear longer, which is because that you're leaning to the right, so you're getting a right concavity and a left convexity. And so we're going to talk about how to name that as well. What you want to look at here is someone is forward bending, and you're looking at, there's the bra strap there, and you're looking at the ribs right there. So the spinous processes would be right there, and you're looking at the rib cage. And as someone bends forwards, if the ribs are elevated on the right, and I think you can see that there, but I'll just kind of draw it. So if you look at this line versus this line, the ribs are elevated on the right, so we're looking at a posterior view of someone as they bend forwards. We are going to call this a right rib hump, H-U-M-P, a right rib hump. And it may not appear to you to be very significant when they're in standing, but with full flexion, it becomes quite pronounced. The textbook on page 460 also has an image of this, but I didn't think it was exaggerated enough, so I went to Dr. Google, and I got an image that was a little more pronounced for right rib hump. Now, not to confuse you, but I do have this image up here from the book, and this is showing something different here. So if this is the spinous process and this is the ribs there, this is showing more of a left rib hump with flexion, because you're getting this rotation of the vertebrae to the left. So this might look a little different in this position as standing, but obviously a scoliosis would cause this right rib hump. And to look at another image, this is a more pronounced scoliosis. You can see quite a significant scoliosis there. So with this, there are different types of scoliotic curves. There are primary curves, and then there are secondary curves. Initially, you're going to have a primary curve that develops. Obviously, in this one, you're looking at the curve that's more pronounced, 58 degrees. So that is the primary curve. So you have a primary thoracic scoliosis, and then because of that, you're going to get this secondary curve at the thoracolumbar junction, but it's less pronounced. So 58 degrees in this example versus 31 degrees. So how are we going to name this? We're going to name this based on the primary curve. So if we look at the cervical spine, the thoracic spine, and we're looking at a bigger curve there, we're going to say this is a right thoracic scoliosis. So right thoracic scoliosis. However, we could also say it also has a left secondary curvature for a thoracolumbar left scoliosis, or left thoracolumbar scoliosis. So sometimes they're paired, but the primary curve is the thoracic, the secondary curve is the lumbar curve, or thoracolumbar in this case, because it's really starting up here at the thoracic spine and continuing to the lumbar spine. Does this condition progress? You can imagine with weight bearing and loading, generally a condition like this will significantly progress over time. That's why bracing or corrective surgery would be critical. However, imagine these numbers are a little bit different. Imagine this is 5 degrees and this is 3 degrees. And there may be many people in the class and many people in the general population that have maybe a 5-degree thoracic scoliosis. There's a certain normality that's associated with curve. Very few people. It's extremely, extremely rare to be a 0-degree frontal plane curvature. It's very rare for that. So there's likely 2, 3, 4, 5 degrees that are normally occurring within the frontal plane. And that typically does not progress over time. However, it can progress over time, especially with lifestyle activities. And if you're in a repetitive activity, let's say you're driving a car a lot, or you're in a certain factory or warehouse setting when you're always doing a repetitive motion to one side, or you're always leaning to the right versus the left, there can be a progression of scoliosis, and it can be symptomatic. But for most people, it is this asymptomatic condition. Okay, so I just asked Alexa to tell me a cheesy joke, and here's what she said. What did the pepperoni say to the mozzarella? You want a piece of me? So that's the joke there. Sorry if you didn't like that. We'll get rid of this. So back to the slide. This is another good slide to just be aware of. There's some numbers in here, such as if the curve is greater than 30 degrees, there's risk of respiratory complications. You can imagine that our ribs obviously are quite impacted by a curvature, and their mechanics are compromised to a great degree if there is that frontal plane abnormality. It is, at a younger age, it does seem to be more common in boys as opposed to girls. Now, when does this happen? A lot of times in elementary school or middle school, there's a screening process. Sometimes this is in health and PE, sometimes this is with your annual physical, but there is this screening process to determine if there's some type of underlying scoliosis. And if there is, a common age to get that done is right around 8 to 10 years old. It depends on how severe the curvature is. But between 25 and 50 degrees, I know that's a big range. There might be a bracing that's considered. And if it's under 20 degrees, and there may be a lot of people under 20 degrees that are completely asymptomatic, there's typically no intervention applied. However, if someone has a 15-degree scoliosis and it's related with a new onset of back pain, it's something that we should be aware of and we might need to consider. So I'll give you a chance to review this slide, but it's good to know some of the information on here as it categorizes scoliosis, and knowing that boys are more common younger to have it and females are more common to have it in the adolescent range. Here's another visual representation of some age-related changes. So if someone's sitting, you can see we're trying to look at a plumb line from the ear down, and there should be some type of alignment, but you can see what happens in these different positions and how things are flexed. And what's interesting to look at here is if you look at slump sitting without a back support and you look at the head position, it's quite far in front. And then if you look at slouch sitting with a back support, you notice actually the head position isn't quite as pronounced. So there's more of an emphasis with slouch sitting on stress on the thoracolumbar area as opposed to the cervicothoracic area. Whereas here, with slump sitting, maybe you're in a stool and you don't have any back support, then there's more of a incidence and problem at the cervicothoracic area. So overall, this is a picture of standing. What would we call this type of posture? You can see there's increased thoracic kyphosis, forward head. There's a posterior pelvic tilt, which is going to increase the amount of lumbar spine flexion, so it's going to reduce the lordosis at the lumbar area. This is known as a sway back deformity. Okay. And what does this cause at the knees? You see they have the knees that are hyperextended. And I got another picture of a knee hyperextension. What do we call that? So genu is knees, and then if they're hyperextended, we call that a recurvatum. And then what kind of end feel would be at the knees? Well, there's nothing stopping it from continuing to go further, so there's definitely not a hard end feel there because there's no bony compression there. What's stopping the tibia from extending further, or what's stopping the femur becoming more anterior? You really just have the capsule and the ligaments preventing that. So it's going to be that softer capsular end feel. And that is this presentation. Hope you enjoyed that, and I'll see you on the next one. Take care.